And so next up, and I'm going to butcher your name, Alex, but is Dr. Hajduczok. He's a superstar cardiology fellow at Thomas Jefferson, and he did his internal medicine at Penn State.
Thanks for having me. Good to be here, good to be back. Thanks, Marwan. Like this says, Dr. Raja Prayer's colleague over at Thomas Jefferson. I stole that from Dr. Rame's talk yesterday. I'm not sure if I'll be able to suggest talk ideas for next year like Dr. Rame did, but hopefully this is still interesting. I have nothing to disclose except that all the Phillies games that I went to against the Astros, the Phillies won. We're not going to talk about the actual outcome of the World Series. And if anybody follows me on Twitter or has met me ever, I don't think I'm wearing the Bills socks right now, but obviously the best team, going to win the Super Bowl. So yeah, just let that sink in a little bit. Back to yesterday, I think it was a really, really moving introduction that we had after the opening remarks, hearing from the patients. Last year I presented a case of AI and cardiogenic shock, and I was really fortunate to be able to share that story. At the time, the patient was still VADed and intubated in the unit, and we didn't know how they were going to do. Fortunately, this case is one of my whys. This gentleman had a pleasure of hanging out with him almost every day when I was on service, getting him to go to cardiac rehab. He even wanted to start doing CrossFit with me, but we told him that wouldn't be a good idea with the VAD. And this is a picture following up of him texting me, "This is me now, and I'm sitting on my sofa, LOL. You take care, thanks for reaching out, I really appreciate it." Those are the little things that really keep us going, and we'll get into the case of aortic stenosis for this year. So, 64-year-old male, rheumatoid arthritis, ILD due to mixed connective tissue disease, on chronic steroids, diabetes, hypertension, hyperlipidemia, so typical patient that we're seeing. Known CAD and known severe AS. He presented to an outside hospital with chest pain, dyspnea on exertion, found to have new HFrEF. EF is down to 5 to 10%. His baseline electrocardiogram showed normal sinus rhythm with a left bundle. And you can see some of the echo images here, reduced EF, poor excursion of the aortic valve. Transthoracic here with Doppler, again, EF at 10%. The mean gradient was 18, valve area 0.67, decreased RV function with moderate TR, and elevated PA pressures. So he's taken for cath. As you can see, elevated right and left-sided pressures. On dobutamine, his index was 2.3. His coronary angiogram showed moderate disease, but nothing requiring intervention. Here's his cath images here, left and right side. So they were taken for a dobutamine echo because of the poor LV function. And at baseline, I see the peak gradient and mean of 28 with a aortic valve area of 0.49 and a resting stroke volume of 39 mils. And with 10 mics per kg per minute of dobutamine, he had improved LV systolic function. Mean gradient was 35 and valve area of 0.6. You can see that the stroke volume increased about 35%. So he was maintained on dobutamine and transferred to our center at Thomas Jefferson in Philly, and for LVAD and plus minus SAVR evaluation, given his age, 64. Seen by heart failure transplant as well as CT surgery, and deemed he wasn't a good LVAD candidate given his ILD, and poor surgical candidate due to chronic steroid use. So consulted the structural heart team for TAVR and recommended TAVR in attempt for improvement of the LV function. I meant to say this at the beginning, but really the bottom line with all of this is figure out how to replace the valve. I don't think that there's any beating around the bush there. So some pre-procedural planning, annulus and LVOT looked good with areas in the 600 range. The sinus valsalva and the sinotubular junction were patent, and the coronary heights were acceptable for TAVR. Some calcification, but nothing prohibitive, and good vasculature for femoral access. And then you're probably wondering when the shock side of things is coming in. It was a pretty stable AS patient up until then. And of course, just like everything that goes to plan, night before the procedure, goes into rapid AFib, and in attempts to stabilizing him, breaks, it goes into junctional rhythm, bradycardic, and started having ectopy and more episodes of polymorphic VT. Fortunately, lost pulses, requiring compressions, ROSC, code blue, and urgently placed on ECMO in attempts to stabilize this patient as bridge him to TAVR. So the next morning, goes to the cath lab or OR for TAVR. As you can see here, a good result. Deployment with rapid pacing for a short amount of time, fortunately, is supported on full support with ECMO. And we have a good result. No AI, and you can see the early post-procedural TTE showed a improvement in LV function, and again, no AI on color Doppler. Luckily, it was, well, not luckily, it was what the attempts of the team and great care that he got up to that point, decannulated on post-day 1, and then required a bi-VICD placement and made it home 10 days later. So let's talk a little bit about the data. This is just one case, but I think that it's something that we commonly see. And really what you're seeing here is CMS data from Masha and colleagues that show in the red on the left side a decrease in the amount of acute cardiogenic shock patients that are coming in for TAVR. But they're still doing pretty poor, as you can see in yellow. Still improving mortality rates, but still upwards of 14%. This is data up to 2017. It was stroke rates pretty steady in the 4% range. On the left side, you see that patients that have acute cardiogenic shock going for TAVR, those curves diverge compared to all patients, which can be explained by the more low risk and intermediate risk patients going for TAVR in general, not in shock. And so when you look at the mortality and the stroke estimates at 30 days and 365 days, it's clear that if you come in with AS requiring TAVR and cardiogenic shock, you have worse outcomes. Significantly worse in mortality, still worse in terms of the stroke risk. Those curves still are statistically significant. Looking at the primary and secondary outcomes, like I said, I guess I should use this before, but you have much worse outcomes in the 30-day mortality in patients with cardiogenic shock and AS requiring TAVR. And the secondary outcomes all hold as well. Now, the interesting part about this is if you look at the procedural success rates, they're actually the same. Why is that important? It's not the driver of the poor outcomes in this case. So if you look at the subgroup of patients with uncomplicated procedures classified by shock status plus or minus cardiogenic shock, the mortality is actually the same as the entire cohort. Again, replace the valve. So really what it shows is that what's driving mortality is the baseline comorbidities or shock state going in. And you can see here the hazard ratios for mortality and stroke. And then, when you look at the pre-procedural inotropes, mechanical assist, which is typically balloon pumps, cardiac arrest or cardiopulmonary bypass, you can see that the hazard ratios are increasing, really underscoring the fact that it's who's coming in with the severity of shock that's driving the poor outcomes in this TAVR population. Just another way of looking at it. This was from the registry, and the control group were very high-risk patients, STS on average of 10, so really sick, even though they weren't in shock. You can see that those patients had a mortality of around 5%, whereas those in shock were closer to 19. And like I mentioned before, in terms of inotropes, mechanical assist, prior cardiac arrest, bypass, had increasing rates of mortality. So what does this mean for TAVR in general? It's a viable option for acute cardiogenic shock. Patients are still at high risk of death at 30 days and remain at high risk for up to a year, according to this data set. Procedural success rates are high and not a function of being in shock state. And mortality is not driven by the complications, but by pre-procedural degree of shock. Didn't really address this, but it comes up a lot as an intermediate step prior to definitive therapy. BAV, you have still intrinsic risk with moderate efficacy, sometimes suboptimal hemodynamic results, still at risk for AI, and a lot of these people actually don't definitively get treatment. They succumb to poor outcomes a lot of times before then with very high mortality rates. So if you look at the comparison between TAVR, SAVR, and BAV alone, this is a small cohort. You have the worst outcomes with just a balloon angioplasty alone. SAVR in green on top has the best outcomes, which in this case can be interpreted as selection bias for patients that were surgical candidates. And in the middle, you have the TAVR people. When you look at the European data from the TAVI shock registry, you can see that at 12 months, the mortality rate is about in the low 60s and still hangs out around a little bit less than 50 at 2 months. And these are AS patients who received TAVR and had a cardiogenic shock. In terms of the trends stateside, you can see on the left that the SAVR group, those are decreasing rates. TAVR also increasing, and the balloon angioplasty group also increasing. A lot of those probably coupled with plan for definitive therapy. And then on the right, you have their outcomes. And what you see is that the worst outcomes are in the BAV group, with the best being in SAVR, again, likely due to the selection bias with TAVR in between. Thank you.
Well, excellent presentation. And I think I'm going to initially ask Dr. Nathan and Dr. Slepian to comment. So I'm getting to the point where I would say I have some historical knowledge. And in the old days, a patient like that would have been referred for surgery. The answer is we would have gone and done it. And the answer is you replace their valve, and if they have difficulty coming off bypass, you provide support. So nowadays, the answer is you all get them. And the idea is, though, I think it's becoming challenging again, though, because of the registry's outcomes and, sort of the oversight that you have to have this sort of, outstanding 1% mortality, and it's sort of nonsense, right, when you put them all together. Because without replacing this guy's valve, right, he wouldn't survive, he wouldn't go home, and he really wasn't a candidate for anything else. So 2 questions. One is, so how do you approach these individuals and deal with them within your program? Anyway, we'll start there. Well, I guess the other was, so the other is in the data, and maybe I can come back and comment. So similar, like in heart transplant, the idea is ECMO is bridge to transplant. The idea is if you put them on ECMO and you can extubate them, their kidneys are okay and their liver okay, they're actually a very good transplant candidate, or very reasonable. But if you put them on ECMO, they're still intubated, have a creatinine of 2 and some congestion, the answer is they're not going to do well. So I sort of also don't understand why in this high-risk group that are going to require some support before, why wouldn't you give them a few days to once again see if the rest of their sort of body is going to recover, and then it becomes a valve procedure. So comments, suggestions?
Yeah, I mean,
I'll get my other surgical colleagues to chime in because those are my biases.
Maybe I'll go first.
Yeah.
I think that these cases are tough. The decision-making is very nuanced. Some of it is based on sort of recoverability of the ventricle. And so, if you have some sense of contractile reserve, you've got the benefit of knowing that this guy had a 30% EF last year. And as the valve has progressed, it's gone down and down and down. There's a good chance that it's going to recover. If you need to dip your toe in those waters and sort of test it, maybe you do a BAV. But the flip side of that is that manipulating, instrumenting that valve multiple times, particularly if there's a lot of calcium, low coronary heights and so forth, is sort of an independent hazard. We've done it, I think, every which way at our institution. One of our fellows is presenting a case tomorrow that sort of touches on some of these decision pathways. Yeah. I will say that in the moment, we're pretty quick to do BAV and just say, let's see what we can recover BAV plus Impella, and then we've done a handful on VA ECMO, but some challenges there as well.
So you basically look for some recovery then
Yep.
before you make the final step.
I think it's important to know the patient. If you've had a history with that patient versus someone who comes in acutely and you really have no concept. It also depends upon what works at your institution. Are you more cath lab dominant with aggressive interventionalists, or are you a little bit more surgically dominant? In our own institution, we've gone flip from having 7 cardiac surgeons to having 1 cardiac surgeon and many more interventionalists, and back and forth. So I think we've handled this in a different way. Your point about knowing about the potential recoverability of the ventricle is very important. But the ability to kind of stabilize the patient just a bit. I mean, here this patient went into AFib in a final death throw, and then you magically, brought him out. But
So we would put 5.5s in all of these patients.
Right.
Yeah. And so, Mark, your point is, again, getting old enough to have history, we've hot potatoed and we're watching how these patients get orphaned, right? They get orphaned from each successive therapy, and because of the outcomes data, there's a pressure not to do TAVR. And so what we do is we put a 5.5 in the patient, we assess their recoverability.
Right.
We give them both, so the 5.5 acts as a BAV, but it doesn't give them the risk of a BAV. We cross the valve. Sometimes we need an interventional cardiologist. Most of the time we don't. We universally go from the left side on these patients. We have reasonable wire skills, right? And we rehab the patient. And then if you show that the patient in 3 or 4 days has decongested, their creatinine is normalized, they can get up and walk, they're off the ventilator, then they can go and the TAVR team can come in and say, now they're an acceptable candidate because we've separated out those patients, process success from the substrate. And the last part is we've had several who've never progressed and they get nothing else, and the families are informed and they withdraw because they're not suitable candidates for anything.
it still speaks to the bigger thing, and sort of what I said again, maybe for next year's session. We have to evolve this dichotomy between interventional cardiology versus surgery, this sort of unified cardiac team strategy. We do that for shock, now we have to do it for these complex valves. We've all survived our MI because of PTCA and stents. So now we're getting to all these later diseases and chronicity and issues, but it requires a different type of team approach rather than just these classic training strategies that we had. So that's for the future.
In some way, we have
But it's now.
we have almost too many options, right? The answer is which one's best.